So let me just start from the top. So I'm Robert Adams. I'm an associate professor of architecture here at Thomas College, and I'm also the director of the University of Michigan Initiative on Disability Studies. My pleasure to welcome you to this first fall Thomas College lecture, and to our many guests across campus from Michigan Medicine, Anthropology, Ross School of Business, the School of Public Health, numerous allied health sciences, and my disabled comrades from disability culture at University of Michigan. Thanks for being here both on site and for joining us via Zoom for a guest lecture by Dr. Bond Koo. Thank you, Katie, for making this event possible. Yeah. Thanks, Katie, and also thank you to Maya for organizing the workshop that we had yesterday evening, and also to the Student Mental Health and Wellbeing Research Team, Sang Wong Khan, Shin Lee, and DJ Koala for mixing the music that really set the tone for what I thought was an amazing workshop last night. A lot of fun, a lot of interesting things were made. I'd like to say that design and health research momentum at Thomas College is due to some amazing colleagues and collaborators who are here today. In the back is Dr. Polly Nanda, Associate Professor of Practice, Director of Research at HKS. Joy Noblock is, I think, joining us online. Joy co-directs our PhD program and is Associate Professor of Architecture. And to my left right here is Dr. Andrew Ibrahim. He's both an Associate Professor of Surgery and also of Architecture and Chief Medical Officer at HOK. So for students, interested in connecting the dots between architecture, health, mental health, disability culture, let's say the politics of space, the medical arts, etc., and how design might address some of the grand challenges facing 21st century life, please follow up with us to learn, so we can learn a bit more about your interest in this space. So I've been thinking, you never really walk into a hospital feeling sick, stressed out, and you say to yourself, this space is so beautiful that I think I could die here. It's been stressful out there over the last 18 months. I'd like to think that in the midst of navigating my own mental health and disability, and let's say all the parameters that really wind up and animate everyday life, that there exist many channels for us to discover new forms of beauty. Or as Elaine Scarry wrote in her book, Beauty and Being Just. This willingness to continually revise one's own location in order to place oneself in the path of beauty is the basic impulse underlying education. So let's just say, to help us align on the path towards beauty, please welcome Dr. Andrew Ibrahim, who will introduce today's speaker. Thank you.
Good afternoon. What a great treat to be here. Let me just underscore a lot of the thank yous that Robert mentioned, including Polly, Joy, and Maya for organizing this event, as well as Robert Adams himself. He's been really instrumental in galvanizing a lot of these efforts around health and design and helping put this event together. I have the awesome privilege to get to introduce a good friend of mine, Bond Koo. He's the Marta and Robert Adelson Professor of Medicine and Design and the Dean of Design at Sydney Kidney Medical College. He got his medical and undergraduate degrees from Penn State, and Princeton. And he really lives in both worlds. He lives in healthcare and design. He's a practicing emergency medicine doctor. In fact, he just worked the overnight shift 2 nights ago, took the next flight out in the morning to be here, took a short nap, and then ran our workshop last night. There's no question he is on the ground of frontline critical care. And he's really been a pioneer of design and health curriculum. He has over 100 medical students currently enrolled in his program who are getting minors in design, who will graduate with skills and tangible outcomes to include design into their medical education and into their medical careers. His work has been highly profiled, that he's directed at the Design Lab, including Fast Company, Architectural Digest, and the New York Times. As sort of a testament to the broad appeal and impact of his work, he has a really best-selling book that's been sold all over the world, just translated into Japanese recently. I have trouble ordering it sometimes because it's on back order, but it's standard reading in my research group for sure. But just speaks to the broad appeal he's had in this space and pioneering it. I have known Bon for a number of years, and I think beyond all of his accomplishments, having a podcast that Fast Company said is kind of mandatory listening for anyone interested in design and creativity. He's also a great human and a great person who is both generous and sincere with his time and collaborating efforts across these disparate fields. And I've watched firsthand a number of people's careers really get launched because of the pioneering work that Bon's been able to pay for us. So please join me in welcoming a good friend of mine, Bon.
I appreciate that. So as Robert was saying, healthcare looks a little bit ugly. So this is what our trauma bay looks like after a resuscitation. And the problems in healthcare are so complex, they're messy, they seem impossible to tackle. And I want to share with you kind of like what I learned in my journey of, looking beyond my own domain expertise of healthcare and reaching out to different disciplines. So looking at designers and seeing how they operate and think and how I applied some of their methods and principles to healthcare. And also want to share with you what maybe the design community can learn from physicians and researchers. So the past 18 months, this is my day job. It's been a little bit busy working on the front lines, but when I'm not doing this type of work, at my medical school, and we're thinking about, how do we create a culture of human-centered design within healthcare? So that's been what I've been working on the past 6 years. But I have a disclaimer. I am not a designer. It's really because of these two people pictured here. They're my parents. They're immigrants from South Korea. They're currently there right now. So they came to this country so their son, me, pictured there, can become a doctor. So I had no choice to become a physician, even though I was fascinated with design growing up. And I have another disclaimer. I'm like really bad at math, and I'm really ashamed of that because, when I say bad, I don't mean like Asian bad, like I got a B+ in calculus. Like I had to move down to the dummy for calculus class. So, for those of you who are maybe experiencing some difficulties with, not doing that well and what you're supposed to be doing well at, it's okay. Pause, breathe. We can expand beyond our own specialty. And so that's what, inspired me a little bit to go into thinking about what design is. So I had this opportunity about 6 years ago to start a design thinking program at my medical school. Only problem is, like I said, I'm not a designer. So I read about design and I found this quote by Paul Rand, and it just confused me more. There's no single definition of design. Design can be art, design can be aesthetics. It's so simple, that's why it's so complicated. So that just confused the heck out of me. I was like, what is design? So I said, let me look at artists and their creativity and how they can be creative. And I love this quote by Austin Kleon. It said, all creative work builds on what came before, nothing is completely original. That gave me a little bit of hope that I could go into this design world and think about, how I can apply design principles to my work. I think Kanye West said it better. Too much emphasis placed on originality. Feel free to take ideas and update them at your will. All great artists take and update. So I was like, I'm going to listen to Kanye West, and that led me onto this design journey across America. Like literally, I found the D School at Stanford, visited them, and I was fascinated that they had this methodology called design thinking. And to me, as a physician, physicians are not so great with ambiguity. So it's nice that they had a little bit of methodology to the design process. And that was helpful for me as I visited their studios. I was just fascinated by even how they look different from the classrooms at my medical school. A lot of post-it notes, colorful, whiteboards everywhere to show their work. then I said, well, why don't I go to Austin to visit IBM? IBM is a global company. They're doing design at scale. I think they have about 3,000 designers at their firm. I got a chance to tour their creative space. And again, like these cool whiteboards, they're showing their work. I reached out to architects. Here's an architecture firm, Kieran Timberlake in Philadelphia. They have the biggest whiteboards I've ever seen in my life. It's literally their entire wall. And again, they're very visual, showing their work, brainstorming. And, you know, what I learned is that it's almost like they have creative gyms, you know, they have design gyms to exercise their creative muscles. So that really inspired me and got me thinking about other art forms and the culinary arts. And here's the test kitchen at a famous restaurant, Noma in Copenhagen. Now that was cool how chefs use some creative time to explore, and it was okay. They had this permission to fail again, and they're like, even these chefs have these whiteboards. So I was like, why is visualizing, you know, so important? And I think what it does, it helps us to connect the dots. It helps us to communicate concepts. So at my hospital, we don't have facilities that look like this. So I started squatting in a basement of one of my buildings, and I started a lab. And you know, was inspired by some of these design studios that I had visited. And I said, you know, can we apply a similar mindset that designers had towards our work in this field of healthcare that's so messy, that's so complicated? And I said, well, first I need some whiteboards. I got some cheap whiteboards there. And I bought some cardboard so I could get us medical students into this mindset of like showing our work. So here's some medical students working on a version of a prototype of an app. And I love this concept of this principle and method of prototyping. We don't do that often in healthcare. I think sometimes we're afraid of prototyping because of concerns around patient safety. So when I talk about prototyping in healthcare, it's not like a neurosurgeon who is, you know, prototyping their techniques right in the OR. You know, Andrew doesn't do that when he's operating on patients. You know, there's techniques that we've learned, but I think there's other ways that we can prototype safely in healthcare. And I thought it was cool. I was like, well, you know, prototype doesn't need to be a medical device. It can just be a sketch. And for me, without a design background, that was illuminating to me. So, you know, we started teaching techniques around prototyping for medical devices, for services, for spaces. We started using just cheap things like Lego. So it was a workshop that we did on reimagining a central venous catheter tray. You know, its place, when you open up this tray to do an emergent procedure, we found that it could be designed a little bit better. So we had just a simple exercise, similar to what the session that Robert did last night, and thought that was like so useful. So we started employing these methods and thinking about new types of products and services. So here's a team of medical students working with industrial design students on how to reimagine the experience of a female patient getting a pelvic exam when there's no pelvic examination table in the emergency department. It's a very dehumanizing procedure. So what we do right now is we flip a bedpan over and perform this very sensitive exam. So they said, well, this is not right. So they created this product called Tilt that can hang on the wall of an emergency room or a clinic, and you can flip it, and it's a more comfortable experience for the patient undergoing this sensitive exam. And healthcare design, we like to geek out about stuff like urine. This is another product developed by students on how to get uncontaminated urine cup. So if anyone who's given a urine sample, you know, it's a little bit difficult, and especially, you know, if you're a female, it's a little bit difficult. Those cups aren't really ergonomically designed. So this team developed a simple system to get a clean urine collection sample. We've seen a lot of prototyping during the pandemic. We've had to come up with solutions like literally in real time, procedures and policies that normally would take months in committees. We couldn't do that anymore. We had to respond to a situation and with hours come up with a way of protecting ourselves, protecting our patients. And it has been one silver lining for the pandemic for me seeing all the creativity around the world. Here's one of my colleagues testing out an airway intubation shield. This is one of the most dangerous procedures that we do in the hospital. We need to protect ourselves. So early on in the pandemic, some of our anesthesiologists had created this airway shield, and we're seeing if that was a way that we could do this procedure safely. Here's one of my favorite experiences in the pandemic. That sounds weird to say, but I got to follow a team from MIT and New York City, 10x Beta. And early on in the pandemic, we were worried that there weren't going to be enough ventilators, looking at the experience of Italy. So engineers from MIT had this prototype of a device that you see on the left that mimics hands around a bag valve resuscitation mask. And that led to the product that you see on the right. Within about like 6 weeks, they were able to mass produce 3,000 of these that are in stockpiles in New York City. Fortunately, these weren't used widely, but I was just amazed that they were able to come up with a medical device within 6 weeks that could be massively deployed at scale. I want to share with you some unique collaborations that resulted from me as a physician working in a hospital, like reaching out to designers. So as Robert was saying, the spaces that we have in hospitals are don't necessarily lead to the best experiences. So we had collaborated with architects and thinking about, how does a built environment impact the decisions that we make? And currently, there weren't great ways of studying this. So this is my colleague, Billy Faircloth. She's an architect at Karen Timberlake, and she would introduce me to some methods that she was using around GIS to map public spaces and look at occupant behavior in those spaces. And I said, well, that's kind of cool. Why don't we map the most chaotic space I could think of, which is our emergency department. And so here's the emergency department that I work in Philadelphia, and here are the typologies of the room in the emergency department. And we started off with this simple prototype of a research method. We said, can we collect information about how the occupants of the emergency department, patients, physicians, nurses, tech move? So fortunately, I had a lot of smart research assistants that summer. One of them, I think, is listening right now, Matt Krasinski, who's an emergency medicine resident here at Michigan. So they would literally stay in the ER 24/7 on shifts, even from at like 2 a.m. and just started mapping behaviors. And what we found is that we could collect a lot of rich information. So we, if the nurse was putting in an IV or a doctor was seeing a patient, we would timestamp that using a paper prototype. They said, well, this is kind of cool. Why don't we take this to the next level? So we used off-the-shelf GIS mapping software, and then we started recording these data. And here's an example of what this data looks like. And we were able to form heat maps of the emergency department. And one study that we did was we looked at which parts of the emergency department led to more interactions between the nurse and the physician or nurse and the patients. And we found that, in one part of the emergency department that was kind of like an unstructured setup that had led to less interaction by about 30 minutes per shift. So I said, well, that's kind of cool. We thought about this visual mapping technique to study our spaces. And you say, well, can we use VR? And so we had reached out to Alan Price, who's a professor at the University of Arts, and he's a VR expert, and he was studying how to map spaces using virtual reality. And we got funding for a study looking at how the built environment impacts burnout among physicians. So the same VR that I just showed you, he did a virtual map of it. And the study that we're conducting right now with my colleagues at my hospital is that we placed a VR headset on a physician, and you could actually walk through the emergency department and put Post-its in this VR setup around and make observations around like, which parts of the emergency room make you stressed out, which, why does this particular space feel like it's giving you a little bit of anxiety? And so we're just trying to see if there's a correlation between space and burnout among physicians. So it's just another tool that we've been using that came up just because I didn't stay within my domain expertise, but I reached out to folks outside of healthcare and looking at what sort of tools they use. One of my favorite tools that we use is 3D printing. And 3D printing is just another way to visualize data. Our design medium in healthcare is data that's generated from patients. So often this data gets, the form factor would be like CT or MRI images. So what we did was we take CT and MRI images, we manipulate that data, and we give it a physical form through 3D printing. And I had no idea what I was doing with this. I met a guy, Matt Griffin, from a desktop 3D printing company, and just started chatting with him. And we purchased a couple of desktop 3D printers and we started experimenting of like, what can we do? Can this be used for surgical planning? Can this be used for training? One of our early projects that we did was working with head and neck surgeons on surgical planning for complex procedures. So here's the current workflow. If you have a cancer that's invading your mandible, you have to put a titanium plate to stabilize your mandible or your jaw. But the current workflow is that they have to bend this plate in the bloody field in the OR. It can be a little bit slippery. Sometimes that can take 30 minutes. So we thought, why don't we 3D print the mandible based upon the CAT scan, pre-bend the plate, autoclave it, then bring that to the, then bring it right into the OR. And so what's nice is that about this procedure is that, often the surgeon does not have to manipulate it further because it's a perfect fit. And that saves time if you're a patient in the operating room. Another case study that we did was 3D printing for complex cesarean delivery. And here's a patient that had a fibroid uterus, and fibroids are these benign tumors. But the problem is if you cut into one of them, there's a lot of bleeding. So we did a case study where we 3D printed the uterus, and that helped guide the surgeons into making a decision to avoid cutting into these fibroid tumors. During the pandemic, there was huge supply chain issues. We've experienced that in multiple ways. So probably most of us have had a COVID test, but at one point last summer, these simple sticks that we put in our noses, they were running out. We didn't have enough supply. So that's critical because if we can't test, we can't chase down this and hunt down this virus. So what we did was we converted our lab into an in-house manufacturing facility where we 3D printed 36,000 of these swabs using an open source file. And we're all about testing in my lab. So it was my colleague testing out one of these 3D printed nasal pharyngeal swabs on himself before we started using it on patients. So we had developed this kind of like test kitchen in the hospital in my research group called the Health Design Lab. And we're coming up with all these kind of like new recipes. I love to cook. I love collecting cookbooks. Here's maybe a quarter of the cookbooks that I have. And I thought, I really want to share these recipes with other people. And I reached out to a well-known design author, graphic designer named Ellen Lupton, who's probably written about 30 cookbooks for graphic design. And I pitched this book to her. I said, hey, can we write a cookbook for healthcare about applying design principles and methods? And so we wrote a book called Health Design Thinking that came out right before the pandemic started. And what was helpful to us was that this cookbook became sort of a field manual where it helped us to generate ideas to apply our creativity during the pandemic. And I want to stress that it's not a formulaic process. It's not a step-by-step formula of how we apply design in healthcare, but it's a very open mindset because the problems are so complex in the healthcare space. So I talked a little bit about how I, as a physician, learned from hanging out with industrial designers, graphic designers, architects, and I want to share, what can the design community learn from us? We have a lot of these vacant lots in Philadelphia. There's tens of thousands of them, and they have a toxic impact upon the people living near their lots. It creates stress in the humans living in some of these neighborhoods. There's a epidemiologist and a research group from Penn who said, hey, why don't we do a randomized controlled trial? It's some of the best research methods you can have to prove a hypothesis, because their hypothesis was, what about if we green some of these vacant lots? We think that's going to have an impact upon their neighborhood. So they got an NIH-funded study, did a randomized controlled trial where they green lots and compared those to that ugly lot that you just saw. And that actually led to decreased crime in those neighborhoods. And it's a very sophisticated study. And I think we could do this more in design, of measuring the impact of our design intent, and to really study, if we claim our design does something, why don't we measure that and see if it is statistically significant. They also found that by greening these lots, it actually led to a physiological impact upon the humans living near that lots, that they actually decreased their heart rate. So heart rate can be used as a surrogate for stress, right? If you're in a high stress fight or flight environment, your heart rate's going to go up. So by the simple act of greening lots was decrease the stress in people living in some of these neighborhoods. Here's one of my favorite examples of graphic design meets evidence. This is work done by Andrew Ibrahim here. So our design medium as researchers are boring scientific articles that we publish in journals. And you see that on the top right there. It's an abstract. An abstract is a quick way to figuring out what that journal article is about. So Andrew said, oh, why don't we make this a lot simpler? Why don't we get the key nuggets of that research article out there? Because now a platform that we communicate a lot is on social media, on Twitter, right? So, and what Andrew did was he did a nice sophisticated study. So he actually, this is the definition of a geek right here. He did a case control study where he actually compared the visual abstract to the normal abstract that we use, and found that the visual abstract led to a lot more engagement on social media. So, his design intent was like, hey, I think this graphic design can help people understand, communicate scientific knowledge better. And he actually proved it with a research study. And now it's become really standard in some of our leading medical journals, like New England Journal of Medicine and the Journal of JAMA. I want to take us back to Philadelphia, where I practice. Philadelphia is a great city. One of the downsides of Philadelphia, though, is the inequity that exists. So the average lifespan of people living in Center City, that's in the background right there, that's where my hospital is, and that zip code, it's about 88 years. That's pretty good. But in neighborhoods like this park, lifespan is about 6 to 8 years. So that median lifespan is equivalent to the lifespan of people living in Iraq. But it's unbelievable to me that you could visually, see another zip code where the lifespan is 20 years greater. So I can't think of what is more inequitable than being born into a zip code where the average lifespan is about 20 years less than another zip code. Many of these neighborhoods, the reasons why are, these social determinants of health, all these factors that impact health that don't happen in a hospital, your income, your schools, access to food. And one of the major drivers for this is race. And because of structural racism, a lot of these neighborhoods that are Black and brown neighborhoods in Philadelphia have had worse health outcomes, worse lifespan. So a principle that we apply a lot is co-design, of honoring the expertise of people living in these communities that we're trying to help. So a few years ago, we went into some of these zip codes where they had low lifespans. Some of these zip codes are at the heart of the opioid epidemic. Philadelphia has one of the highest rates of opioid use and deaths for a city on the East Coast. Some of these neighborhoods like Kensington were hit really hard. So instead of us, thinking about an intervention in our lab and then devising a policy recommendation, like, why don't we go out to the community and start hosting workshops where we honor the expertise of the people living in these communities. And we applied for a couple of design grants going through the Community Design Collaborative. And I got a lot of inspiration for some architects out at Kansas University who had bought a vintage Airstream trailer, repurposed that, and started taking that out into the community and started doing like creative placemaking. I have no idea what creative placemaking is, but I was like, well, this sounds cool. These going into some of these parks that were hit so hard by the opiate epidemic that literally the librarians were using naloxone to resuscitate people who had overdosed in those parks. So we had gone into some of these parks and thought, what is a way to reimagine this public space and engage with people there. So here's an early sketch of of what that Airstream might look like. We thought we should pop open the door so people can know what's inside there, so that they're not scared of what's going on. And we spent a year building out this Airstream that we use to do blood pressure screenings. And here we're having an interactive exhibit and asking community members of what are they hopeful? What brings hope in their neighborhood? What are some ways to improve their neighborhood? So it was a fun, creative way to think about how to engage with people in their own neighborhoods. And these cool Airstreams shouldn't just exist in the pop-up parks and beer gardens for folks, but we should really try to bring some beauty into these spaces. So during the pandemic, we had to repurpose our Airstream into a base camp for a COVID testing site. So we did this right on in the pandemic. And what we found was that these communities that were hit hard by the opioid epidemic, they were also exactly the same communities that got ravaged by the pandemic, that they were having worse health outcomes. And not only was there decreased access to food with these food deserts, there were also COVID testing deserts. It was hard to get a COVID test. So what we did was, we set up these mobile testing sites in church parking lots and school parking lots. There's a school parking lot in Southwest Philly. And we made it easy for people living in that neighborhood to get access to a COVID test. Here's a journey map of what it's like to get a COVID test in a parking lot of a church that we set up in Northwest Philly. And we wanted to make that experience a good one for people getting a COVID test, because if we want to eliminate some of these barriers that existed already in these communities and this fear of this virus. So we did COVID testing, we're still doing that, but then when the vaccines came out, we're like, well, we gotta bring vaccines into these same communities, because some of these communities have had the lowest vaccination rate. So overall in Philadelphia, currently we're doing great. 80% of our city has had at least one dose of the vaccine, but there's still zip codes, and the same zip codes I've been talking about, that have less than 40% vaccination rate. So what we did was we set up the mobile vaccination sites in these communities. We partnered with leaders or community members who were already plugged into these communities. So one of my favorite collaborations involved tacos and COVID vaccine. So South Philly Barbacoa is one of my favorite restaurants. Christina Martinez is owns a restaurant with her husband Ben. There's a whole Netflix episode on her on Chef's Table, and she has she herself is undocumented, and she has a relationship with the Latino community in South Philadelphia. Much of that population is not vaccinated, and the reason why they're not, they believe in the vaccine, but they're not vaccine resistant. But it's scary if you're undocumented to go on site to a website, put in your personal information, go to like a Rite-Aid CVS. So we work with Christina to hold a couple of these pop-up vaccine sites where like, you don't need an ID, you don't even need to tell us your name, you can just come and get a vaccine. And by working with her, for me, that helped with some of my biases, because a lot of us physicians were like, oh, why aren't these people vaccinated? They're vaccine resistant. There are other reasons why people are afraid to get the vaccines. So we've been currently operating a lot of these vaccine sites. Here's one at a park in South Philadelphia at a Latino soccer league. So many of these people who are vaccinated at this park, it's hard for them to get a vaccine because they're working 12-hour days in a restaurant Monday through Saturday. On Sundays, they have the soccer league. So like, why don't we bring our vaccine distribution site there? And because we already had this mindset of like healthcare can happen, outside of the walls of the hospital, we felt that it was important to go into these communities, co-design with them, like how to reduce these barriers for people to get vaccines, to get tested. This is a picture from the awesome workshop held last night. And what I appreciated about that workshop was that there were students and faculty from all different parts of the university. And I think these collisions that Andrew was talking about, we need to do more of that stuff. It really sparks a lot of creativity, and I look forward to continuing to work with faculty outside my domain expertise, students, because I think that is where a lot of innovation can happen. So I'm grateful for Dean Massey for inviting me here, for Andrew and all the rest of the faculty, and I hope that we can work together to create better health in the future. Thank you.
Could you take a few questions?
Oh yeah,
Thank
oh,
you.
Yeah.
Let's open it up to questions that you have. Maya's capturing questions from Zoom, so if there's anything there, we can start with that.
Oh yeah, in the Zoom world, we'll take questions for you behind the laptop as well.
Oh, go ahead, please.
When what systems or infrastructures did you consider for, how to prepare the vaccine, how to be able to really make it accessible to that degree? What government policies or healthcare policies did you have to navigate, as well as the student?
Yeah. So the question for the virtual audience is, what sort of setup and preparation do we have to do to deliver vaccines through this 1964 vintage Airstream? And what you saw was a FordX mobile vaccine, a transit van. So we had actually reached out. So that's our main vehicle that we use. So Ford has a innovation division called FordX, where they build these mobile health units. They converted some of their transit vans to deliver healthcare literally on the street. So within that van is a pharmacy grade refrigerator, because these vaccines have to be kept at a constant temperature, low temperature. So if we were like, well, and then we actually have to put information in electronic healthcare record system. So we actually literally have to go into a site, set up a Wi-Fi network, have a pharmacy grade refrigerator. And so those are some of the preparations that we did to make it. Just because we're mobile doesn't mean that we're cutting corners, but it was the same thing if you walked into a CVS or Rite Aid. we use the same sort of procedures and policies to deliver vaccines. And then with the Pfizer and Moderna, we gave out Pfizer, we went back into the community 3 weeks later to get the second dose. Yeah.
Very lighthearted question. Like, what do you do in your spare time? I'm just curious.
Oh, yeah.
How do you have spare time? What do you do if you do?
Oh, I love this personal question. What do I do in my spare time?
It's a little personal question.
Yeah.
I was just wondering, that's all.
Well, there's actually a lot of things I do. Well, one, I like to read books on design, which is like weird because I don't have any formal training in design. So and then I had a pandemic hobby of starting a podcast because I miss traveling and engaging with people. So the podcast is like my pandemic hobby. So every week I get to interview someone new and spend an hour with them, and they gift me with this hour of great conversation. And then me and my producer, we edit that and we give them out, open source it to other people to listen. So I had a student today who was like, "Oh, I listened to your podcast." I was like, "Oh, that's so cool. I'm surprised people listen." Yeah. So that's one of my pandemic hobbies I do in my spare time. And I'm a big surfer, so I surf a lot on the East Coast. I'm missing a big swell right now from a tropical depression. How about, okay.
But why don't you get those
Okay,
first?
back.
Okay. So I know you said that you visited under like 1,000 how many have you served so far?
I'm sorry.
How many have you been able to do the vaccination? You visit I know you said that you visit them like for the Pfizer vaccine periods after, but how many have you served otherwise?
Great, yeah. So questions around vaccine delivery are volume. So we've done today about 3,500 vaccines. So I think that number is a lot because it's in zip codes that have had a lot of hesitancy or decreased access to vaccines. So in the beginning, we're seeing these mass vaccination sites where we have the convention center, people will go like, thousands a day would get vaccinated. But when I started talking to people in these neighborhoods, even for them to go 2 miles to that convention site, it was a big deal. Like they did not want to do that. But because we were there in their neighborhood, that reduced these barriers. So we were able to give, and most of the people who are vaccinated are people of color through our mobile sites.
Yeah, so we have a question from the chat. Ben Basson asks about that you have this really unique academic role. How did you get your academic medical center to embrace the combination of medicine and design and recognize it with a formal role, appointment, or professorship?
Great. So the question of like, how do we maybe build this kind of culture of human-centered design at academic medical school? I think a lot of times we think we need like a lot of funding to start something, but we literally sort of like hacked it as we made up. So we started squatting in this one place that wasn't really used in our hospital. That's where we built our lab, and then we just started like doing projects and showing that impact, smaller projects, and storytelling around that. I think in medicine, we don't do a great job at that. I learned a lot there from designers. You all do a great job with visual storytelling. And so we adopted some of these like principles and methods of like, how do we show our work? How do we show our impact in a very visual way? And then we started gaining some traction, and people just started finding us and say, hey, we have this problem that we want to work on. How can we work with you?
And like for med students, when you introduce design thinking to them, do you have to convince them? Are they already interested? And also when they do like participate, is it out of kind of like frustration or more like eagerness to find some?
Great. A question is, what do medical students think about design thinking? And I think as humans, we hunger for creativity. And when I have kids, and when they grew up, they were, when I look at them, I was like, well, they're just prototyping. It's like their natural way to learn, and they're visual. But I think in the school system that we have, the educational system, we beat the creativity out of people. And there's no better people that beat creativity out of humans than medical school educators like myself, right? Because we have a long system of multiple choice question tests, and we are the masters of multiple choice question tests. Any doctor, I guarantee you, no one can beat us at that. And so we've become masters of memorization, regurgitating that memorization, and you need a knowledge base. I mean, medicine's hard, but there is little room during the training process to be creative, to have space to explore. And I think for the medical students in our program, we have a longitudinal design program for 25 students per year. There's a hunger for that of here's a free space to prototype, to think outside the box, to collaborate with people outside of medicine. So for me, I felt like my creativity went into hibernation, and I was always jealous of architects and designers, and they seem like they're so creative and doing cool stuff. And I'm here memorizing material and taking multiple choice question tests. So I think it's refreshing for students and physicians to use their creative muscles, because we don't get to flex those often within the current educational system.
I'm curious to what extent you collaborate with administrators, and because I know there's so much regulation and so much compliance within administration. I'm curious if there are other there to help facilitate.
So a question is, collaborating with administrators and other stakeholders, critically important, right? If you look at an insurance bill, someone designed that thing. Every service that you see in the hospital, they may not think they were designing it, but they were. Every product, experience, space. I mean, healthcare is an experience. It's a service, and it's just a badly designed service. So I think it's critical to get all the stakeholders, whether you work in environmental services, you're a nurse, you're an administrator. A lot of the policies that we have in medicine are poorly designed. So I think it's important to work with all stakeholders in that ecosystem. And healthcare is so siloed. We don't speak to each other. I think that's why we have such a fragmented delivery system, and why our experience of it is often not a great one. So it's critically important to work with administrators and other stakeholders.
When you show the case study about the hospitals and the behavior aspect of and the nurses and the doctors, does context play a role when we design something, a product or a prototype?
Does context play a role when we design a product?
Where they're doing it. So
Yeah, context is critical. I think the most creative part of the design process for me is understanding the problem. I think that is a creative journey. I think often we think we understand the problem, but sometimes we don't understand the right context for it. So I often see this at emergency department overcrowding, for example. Why are there 50 patients waiting to be seen and there's an 8-hour wait? The default would be, hey, it's because we need a bigger emergency department. We need more rooms. But often when you look at it, it's more of a policy issue that goes on of we could board patients in hallways, or there's not actually enough staffing. Often when I look at the ratio of how many patients are boarding in the ER, boarding means you're admitted to hospital waiting for a bed. Let's say there's 20 of them. Often that equals the number of patients in the waiting room, there's 20 in the waiting room. So it's we have the space, but we don't have the correct policy setup. So I think context is key for us to come up with design solutions. Great question.
So there are a lot of great questions in the chat. I don't think we're gonna have time for everyone, but one that I think would interest a lot of people here is what steps would you suggest to folks who are new to the field if they want to become more involved and learn more about it?
Great. Okay. So steps if you're new to the field, to find like-minded people, to find who want to work on the same problem. And it does not need to be a lot of people. And to take on one problem that's bite-sized and to work on it, to brainstorm, to come up with a solution, even if it may not be implemented, but to just go through that exercise. And that's what we were doing before, right? You know, healthcare is such a huge part of our experience as humans. It's a huge part of our economy. It's like 90% of our GDP. And to take like a bite-sized problem and work on it and to find like-minded people, because I guarantee you some of the frustrations that you have with health, your health journey, healthcare, there's someone else out there who feels exactly the same way. I'm working on it.
I need a couple more.
Okay.
So I'm trying to understand how two zip codes in the same city can have a 20-year difference in life expectancy. So could you elaborate on that? And what do you think are actionable changes?
Sure. So why do people die at sort of varying rates, or why do people live at varying rates in cities? It's the social determinants of health. You know, some zip codes have you know, worse access to healthcare, to healthy food, to employment, schools. You know, most of that impacts health a lot more than what I actually do in the hospital, what doctors do in a clinic. You know, that there's been studies saying that you know, what we do in the healthcare delivery system only impacts 20% of overall health, but all of these other non-medical factors have a huge impact on health. So, you know, what can we do? I don't know, but I think it's important that we go out into these neighborhoods and co-design solutions with them. I think too often we design solutions without the input of the humans that we're designing for. So instead of designing for, designing with.
I feel like a lot of people feel that healthcare is pretty opaque in this country, and like the work that you're doing to sort of use design storytelling to explain to each other, like to other people in the field. Is there any kind of feature you think of like transferring that knowledge just to a wider public, just so that they can also maybe be involved in the process?
Great question. Maybe how can we accelerate maybe these types of collaborations? I think something like this is, you know, forums like this is great. You know, your dean's doing a great job hosting these forums where you get in different perspectives, right? And you know, healthcare needs design. We need different ways of thinking, and you know, and some of the ways that we think can be helpful for people who aren't researchers, for example. So I look at some of these programs within the architecture school, they're super innovative, right? They're like hybrid ways of thinking. I think there is a tendency in academia to stay in your own domain expertise and go very deep, right? And go, I am the expert of this thing. No, you know, I'm smarter than everyone else. But it's a little bit scary to leave your domain expertise and we're like, whoa, what is this person doing? How can I learn about that? How can we collaborate together? So I'm grateful for opportunities like this that I think help bring people from different disciplines together.
One last question.
Last question.
Yeah. So this is sort of a combination of two questions, both about working with communities. One is about sort of in the context of the opioid crisis, what are communities asking for that maybe you wouldn't have predicted as a designer going in? What is the expertise that they're bringing to that? And then also a question about kind of thinking about cultural differences when you're working on design.
Yeah. Ooh. Those are great questions. Maybe I'll just sum this up. Like, you know, what I learned from working in communities hit hard by the opioid epidemic. I was at one stakeholder meeting, and I was like, yeah, this neighborhood has been hit so hard by opioids, and it's like, you know, why is that? Is it because of policing? Is it because of some of these policies? And then, you know, one guy just said, well, it's because of racism. I was like, whoa, you know, like, I'm like, you're right, you know, and kind of like what I've learned is, you know, how structural racism impacts health. You know, I talked about, there's a slide about health justice. Improving health is a justice. It's an act of social justice. It's not just, it's just not, you know, improving kind of like medical outcomes. But I think for me, I've often been humbled and often have learned about my own biases as a physician, because I'm often the expert, someone coming in with authority, but by listening to the community, by co-designing, you know, I've learned to grow by understanding my own biases that are great.
Dr. Bonk, thank you so much. Here's something you can wear in the emergency room. Here's that.
Oh, I love it. I love it.
Thanks for everybody. Thanks, Dr. Pugh. Thanks for the organization. Thanks for joining us online, and we'll stay in touch. Have a good afternoon.